Welcome to today's presentation by Arista MD and Corstrata, Measuring Success in Wound and Ostomy Care. My name is Kate McDonald. I am the Marketing Operations Director here at Arista MD, and I want to introduce Myra Varnado. Myra, could you please come on screen and introduce yourself for us?
My name's Myra Varnado. I'm a wound and ostomy nurse specialist. I work with Arista MD through Corstrata. We are a channel partner with Arista, and we see a variety of different types of patients who have wound and ostomy issues, some who have skin issues. And we, all of our nurses are board certified wound and ostomy nurses. So we all know the benefits of using telemedicine for sure. So let me tell you the benefits of using Corstrata. Telehealth, as you know, is exploding, and in this year, so we're still in 2021, over 25 million Americans had a telehealth encounter, whether it was a physician model or a home health or hospice model or any of the at-home models that we're starting to see. But patients were seen everywhere, all over the place. And that is the beauty of Corstrata, is that we can see patients really in pretty much any setting. Let me just go through the steps of how we receive your consult. Essentially, you initiate it, that you need a consult in Arista, and then you will send us you'll send the clinical documentation, and we ask that you send a visual wound photo, which is really pretty important. At that point, Corstrata will have a nurse take a look at everything. We will take all of your photographs, your clinical documentation into account and make recommendations. We also will give you some resources that would be helpful for you, perhaps if it's a wound dressing, for example, that you may not be familiar with. And then we provide patient education materials also for your patients. And then the last step is step 4. And that's just where, once we're finished with our consult, we just wait for you to request our assistance again, and we can certainly follow up on those patients for you as well. One of the most important things in wound healing is identifying wound etiology. And we now know that some of the problem that we have with some chronic wounds is that the true etiology was not actually identified. So a patient maybe has been being treated for something that was not really the right thing. So it's really important that we do know the etiology or try to figure it out. Because etiology is going to guide our care plan. It's going to consider the role of a variety of systemic factors that would take place. Also, it's going to optimize the impact of healing and disease management. And we want to do that to prevent recidivism. You know, we're managing, but we always want to prevent a recurrence. So let me give you an example of why the wound etiology would be important. And we're going to talk about lower extremities a lot today, but they give us some really good examples of what I'm trying to explain. As you know, the gold standard for venous insufficiency management is therapeutic compression, and that's going to typically be 40 to 50 millimeters of mercury. However, you can imagine, like with compression and you've got PAD, that's not something we would want to do. Okay, so we don't want to use anything in PAD patients that's going to impair even more blood flow to the wound. So knowing the etiology will help us to make the right decision on what this patient is going to need and what they can tolerate. We see a variety of types of wounds. You know, of course, some of them are acute, you know, those are a sudden occurrence, and that would be certainly trauma-related wounds, whether they're penetrating or dull trauma. And then, of course, surgical incisions, you know, that is, that's a wound that is acute. And then we have the other wounds that are just chronic and non-healing, and they, you know, typically we see it with a lot of lower extremity wounds. We see it with a lot of pressure injuries, and we'll see it with surgical incisions as well, that they just over time, they're not progressing. There's a couple of definitions of chronicity of wounds. One says after a month, if the wound's not making progress, consider it to be chronic. Another reference says after 2 months. The bottom line is, we know that you should be seeing progress if you're doing the right thing, and if the patient's doing what they need to be doing as well. Okay, so if we're not seeing progress, we need to kind of step back and take a look and figure out why. And again, we do also see patients who have skin issues like poderma, moisture-associated skin damage, or intertrigo, and those types of skin issues, as well as ostomy. And again, we want to just prevent recurrence as much as we can, manage them and prevent the recurrence. So there's some real value in engaging a specialist, and I'm kind of preaching to Kate's choir here. You have greater access to experience and very focal experience. You get good site of care alternatives, and we can see our patients in any setting. We see patients in long-term care, we see them in home care, we see them in doctor's offices, and then we do store and forward as we do with you. The other thing we're wanting to do, you don't want your patient to get lost like in high traffic areas like the ED, because they just get lost, and it may be hard for them to come back to you. When you're using Arista, you're able to keep your patient in your health system, which is extremely important. The other great thing about Corstrata telemedicine is we're able to, as I said, we can see patients in any site of care and in any place. So for example, it might be a rural patient, and we see a lot of rural patients, but we also see a lot of urban patients. And sometimes I have patients, particularly for ostomy, who I have 5 in New York City right now, all with ostomies, who don't have access to an ostomy clinic. So that's the beauty of having wound and ostomy telemedicine available. Our goal always is the gold standard. We're going to use proven best practices, advanced wound healing, and advanced technologies. We're starting to investigate some wearable technologies, and we're kind of real excited about those because they're really good for giving us great feedback in between times of seeing wounds. The other thing is this is just a cost-effective option, and it really does improve your patient's experience, and because it puts the patient in the center of the care. Where you can generate value with Arista and Corstrata is in access to augment knowledge, follow advanced wound healing best practices, and proceed with confidence. Okay, that's the access piece. We just kind of talked about that. But then payer satisfaction. Payers really are looking at what we're doing now. They like for us to see patients through telehealth. They are giving pre-auths, and they are starting to do more billing. So what we're seeing is that the payers are seeing the value. And then just trying to get out of a habit of overly relying on like ambulatory modalities. Sometimes it's hard for your patients to get there. Sometimes it's very extraordinarily expensive, like if they have to have an ambulance, to transport. We like to adopt just post-acute service protocols and, manage these patients outside of a wound center, because so many of them can be. They don't all have to go. So the wounds of concern that you would want to consider consulting on would be our lower extremity wounds, and particularly the ones that get complex, that have a mixed etiology, pressure injuries, patients with stable eschar, unknown etiology, stalled wounds, and then anything, it can be a simple wound or it could be a very complex wound. Just in talking through wounds, let's just talk just a minute about venous insufficiency. I'll tell you that 70% of the lower extremity wounds that we see are venous. And it is related to chronic venous insufficiency and venous compromise. But here's what's really kind of an important thing to know is that the onset typically is going to be related to trauma. So these are those patients who will tell you, I cut my leg and it just wouldn't close. It didn't look that bad. It just never would close. Well, guess what? They had venous insufficiency and they didn't realize it. They didn't know it until they had some type of trauma. So we know we use therapeutic compression. We need to know about all the comorbidities because they can influence our management. And then again, we're going to look at lower compression options for that mixed lower extremity venous and arterial disease. And then we have management goals. So for venous, it would be we're wanting to promote the venous return and control the edema, manage the exudate, and protect intact skin because these are pretty heavily exudative. Avoid sensitizers and irritants that can cause dermatitis, like perfumed lotions on the intact skin. You want to prevent and eliminate infection. You want to protect from injury, because the one thing we know in some recent research is among those patients who do have recidivism, the reason is from another injury, and it may be the exact same injury. So they're going in front of the car and the license plate gets them on the leg, so protecting from injury, again, that's going to be a lot of our prevention measures. Stimulating granulation tissue is always a goal. And then identify the long-term compression plan. Because if patients are just going to keep coming through, and we're going to keep doing the same things over and over and over again, and we're just kind of spinning our wheels. So we need to come up with a plan that can be a long-term plan for these patients. So let's go through a consult flow so you can see. So this is a patient who was a 57-year-old male patient. He went to the ER about 3 weeks ago, and he had a left lower extremity ulceration. He also had some cellulitis. He required an inpatient stay for IV antibiotics. He had no history of any kind of venous or arterial insufficiency, and no chronic comorbidities were noted. We did not have an ABI value, though, and that was something that we would like to have seen. The current management plan for this patient was a daily dressing change, which was cleanse the wound with soap and water, cover with a gauze, and secure with an ACE wrap. Okay, so this is the clinical information that was offered. Left lower extremity is moderately edematous with the 2+ pitting edema noted above and below the margins outside the wrap previously in place. Based upon the edema described, it appears that the wrap was applied starting at the ankle and extending to the mid-calf. And then they go through and start talking about the wound. The appearance of this wound resembles a venous wound based on it's irregularly shaped, it's shallow in depth. It has a variety of tissue types from mild necrotic tissue on the wound edge to granulation and epithelium. These are, again, moderately exudative, and it's not unusual to see mild peri-wound maceration at the edge. And these patients have really minimal to no complaints of pain typically. So Arista will identify an available Corstrata WOC nurse, and the current clinical information that the physician provided, including photographs, will be provided to the Corstrata nurse. The Corstrata nurse then is going to review all the information, recommend confirmation of etiology, and then review any photos. And really, one thing that we do have a really great specialty software that we can use for photographs, and that can really be very beneficial a whole lot of the time. So we would go through that, and then if we have other questions, we'll let you know. So for example, if I'm reviewing a patient and then I say, oh, I really needed this other piece of information, I can send you a note and ask you for it. You can send it back to me, and then I'll complete the recommendations. So we assess and identify etiology, and this is what the recommendation was. Okay, we want to always rule out PAD. We recommend a bedside ABI, and this is a really beautiful resource from the American Heart Association for how to do one. Really, they're done at the bedside, and they can be used. The only thing is you do need a Doppler. Always address the edema, because that's going to impact cellulitis, and then consider a weekly application of an appropriate level of compression that would correspond with this individual patient's vascular status. Okay, so then we look at the care instructions, and this would be the recommendation for a dressing. Cleanse the entire lower extremity with wound cleanser, pat dry, cover with non-bordered foam dressing. If the patient has a lot of inflammation or is infected, you can use certainly a silver option. Now, your ABI, the ABI is 0.5 to 0.8. Coban 2 light is an appropriate type of compression that can be used, and it is the only compression that has clinical evidence to support using in patients who have an ABI as low as greater than 0.5. So this is really, this is a great option for us to have for some of our patients who have needed compression, but they couldn't get it because of their mixed disease. If the ABI is greater than or equal to 0.8, then just a regular Coban 2 dressing would once a week would be fine. And again, one of the things that we try to do is provide you with some resources along the way. So this is the link to go to Wound Source, and it'll tell you everything you want to know about this dressing. It'll give you the clinical evidence. It will tell you the research that was done on it. It will go into the information I just gave you about the low ABI. So this is, I think a real great benefit to be able to share these resources with you all. And then we provide patient education recommendations. And I'm not going to read all these to you, but these are just some examples, and they're very common sense. They're very common sense because we know patients are not going to sit with their legs up forever, right? So we give them options that if they have to dangle, that they can do certain things, rock in a chair, do toe lifts, stand by something and just hold on and do the toe lifts up and down, anything to move that posterior calf muscle. We want it pumping. And so, there are other options than just elevating legs. And then these are the references for the information that I gave to the physician. And that's it. This is Corstrata, our team. We have been in practice for going on 6 years. We are based out of Savannah, Georgia. We all live all over the place because we're totally remote. 100% of what we do is virtual. And we hope to serve you. We would love to see your patients. We very much enjoy seeing your patients.